you're dealing with very wide variety of patients, and wide variety of thinking around. هو احنا we're turning from ophthalmology to head and face practice. So we added dermatology, maxillofacial, dentistry, and the dermatologist realized two things when doing this: that the dermatologist, their laser can be used with special indication in our indication. So we provide the patient what the patient wants. I want all laser, right? It doesn't really provide anything else over the scalpel, if you think about it, and the diathermy. But still, it's an extra service for the patient when they need, and it's chargeable as well. And the other thing you realize that we as ophthalmologists are being robbed by the machinery, the industry, because you can buy a whole set of laser, alexandrite, diode, excimer for the dermatology for half a price of a machine, an OCT. And you cannot believe how much we are really being abused by the companies. And so you guys are elegant, you can pay. Come on, guys, So the cost in ophthalmology is very expensive. If you combine this with dermatologist, and you have several use of cataract. The real use actually is the neurofibromatosis case and the tumor case, because here the bleeding is excessive, and when you generate the heat up to, you don't never go up to 40 watt, 3, 4, 5 watts. It's really hemostatic, so you can have a cleaner set of view of the field as well. Using it for 1 year now. Yeah, it's really nice. Excellent results. The scarring is minimal. The edema is minimal post-operative. But you just have to wait a bit, 2 more days to remove the superior. Superior, inferior, it's beautiful because you don't crush tissues, you don't do anything. And the healing of the conjunctiva is beautiful if you go transconjunctiva. Whatever you want, sir. And the machine cost is minimal. How much you charge the patient, it's as you wish. But I mean, it's nothing. Well, I got the whole set of all kinds of laser for half price of an OCT, which is we're being exploited, guys. Wallahi, believe me.
So we'll have Dr. Hakim talk to us about pitfalls in blepharoplasty.
Thank you so much.
And then we'll have a good section on complications later on.
Okay, thank you so much for being here today with you. My talk is about
2 weeks, and I look like myself, except a better version, and I'm really happy. Thanks.
هذا الدفاع هاي أخطاء شكل وهي أخطاء
a lot of problems. This is a picture actually after surgery. It's complaining from a lot of things which I cannot see, but this is how she's complaining after surgery.
بس ده لما بتتحكي لكن انت فاتحه عادي.
I ask her this happens sometimes, but she says that happens most of the time. Now she's complaining from the left side, which I don't see anything, but she's complaining. She asks, is her legs going down? This is what happens in the blepharoplasty. This is a side which we don't like in the blepharoplasty. This is our nightmare, actually. Small errors is a big unhappiness. This is what we are facing in the blepharoplasty. And this is what we are trying to talk about. Not the complication, but the small errors which we are facing. And they make our life is very, very tough with the blepharoplasty. So the first thing, the most important thing which I'm facing is the asymmetry. It is not the surgeon, the one led, but the asymmetry. You can see here, the incision is here, the incision is a little bit up, maybe 1-2 meters, but 2 millimeters, but everything is very bad. And the patient doesn't like her shape. Another patient which has also asymmetry. This is one like that, this is the one like that. But if you look pre-operatively, she actually asymmetric also pre-operatively. But if you compare, this is a pre-op, this is a post-op, and there is asymmetric pre-op, and consequently there is asymmetric post-op. And accordingly, it is not assessed properly before the surgery. Another patient which has asymmetry. Here you can see asymmetry. This is a larger area. This is a smaller area. It is asymmetric. She is an unhappy patient again. If you look pre-operatively, it looks normal. There is nothing wrong in her eyes. But why she's asymmetric? Again, let's examine again. The incisions is good. The space is good. Everything is perfect. It is not such asymmetric like the first patient, but still the post-operatively asymmetric. Then we go back again to examine her photo pre-operatively. It check there is a small area here, but it is not here. It is minimal asymmetry pre-operatively reflected back in the post-operatively. There is more skin here, little bit more skin, and accordingly in the surgery, if you look here, this small skin is residual after doing my surgery. I take measurement on the right, on the left, but at the end I have small residual as the upper part, which I have to go and excise it. So even minimal asymmetry preoperatively, which you can miss it easily, you will be reflected back after our surgery, and the patient will be unhappy, and you have to go and correct it. This is asymmetry not from my surgery, but it is existing preoperatively, and for sure, improper preoperative assessment and discussion with the patient. Another patient who has asymmetry again, you can see this is incision here, this is asymmetry, the lead is not doing in the proper way. If you look here, my incision is not good. Actually, I didn't follow it properly. He has a lot of excess skin preoperatively, and when I go evening, I couldn't make my mark properly. So the message, the goal is not just to remove, but to create harmonies between the two eyes. A small error will be magnified significantly. So the blepharoplasty is not a surgery. It is making harmony between the upper eyes. Overlooking preoperative asymmetry, discuss it probably, and the meticulous marketing. This is very important to avoid. This is very common pitfall. You have to discuss, you have to examine too, you have to look at. The second nightmare again is excess excision removal, which is lag of thalamus. It's very, very critical. You will see it, how much this kills us sometimes. Look, this patient, this has short skin here is good. She's complaining from the right eye. Too much complaining. This patient came to me, too much complaining. It's not my patient, but I have some patient like this patient. If she's opening her eye, she's not so bad. Why she's complaining? Everything looks fine. She has a shortening, but the lens looks normal. But she is odd and she can't sleep, especially when you wake up. But if you look, there is no Bell's phenomenon of this patient. No Bell's phenomenon on the right side, no Bell's phenomenon on the left side. And so even the lag of thalamus, which is about 1 millimeter, make her very dry when she sleep, and she has a problem when she wake up. She has dryness, and she is coming to me, please help me to get rid of this one. So usually what we have to follow is that at least we have to have 2 centimeters. This is a golden rule in the blepharoplasty. You have to have at least 2 centimeters. In the left side, she's much better, the 1.8, but here she was 1.5 centimeter. So at least you have residual 2 centimeters in the upper lid to be sure away from the lag of thalamus. So evaluating for the Bell's phenomena, evaluating for the dry eye, always err to the side of less. Don't take more. Always go for the less, because you can correct it, but the more you cannot do anything. The second thing is the postoperative ptosis. This is sometimes we face it. This is a patient, she has some ptosis postoperatively. Even the crease is not, the symmetry is not bad, but she has some ptosis. Again, when we go to the preoperative, we will find the ptosis was existing preoperatively, and so I have to manage it even postoperatively. So preoperatively, she has a ptosis, and postoperatively, she has a ptosis, but I was missed it preoperatively. So we have to evaluate properly. We have to know what we are doing. Adequate preoperative assessment, precise dissection for the plane, all of this help you to avoid the ptosis. Lateral hooding, this is very common. I faced it. You can see it here. The lateral part is excess skin. The patient is not happy. This is, we call it lateral hooding, but this is OU. If it came again, lateral hooding here, excess skin here, the patient is unhappy. If he came again to the first patient, which is complaining, and I don't know what she has exactly, we'll find there is residual lateral hooding here, and she was insisting this is very annoying here. It is very minimal, but annoying the patient. So lateral hooding unilaterally here, make her complaining, all of this complaint. So it is very meticulous surgery. It is very meticulous surgery which we are doing, and you have to be very careful. So we talked about the marking. Preoperative marking is very, 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 very important. How we are doing it. Preoperative marking is very important, and when we are taking our incision, we go laterally up. When we go laterally up to avoid the lateral hooding. If we look finally how we are making our marking, we take the mark usually. For me, I measure about 1 centimeter from here or the upper border of the tarsus. Then we go laterally here. We don't go like that. We have to go laterally here to excise the lateral part to avoid the lateral hooding. This is a very important step. We don't usually follow like that, like our crease looks like. We have to go here, then we have to jump up, and then we excise. So excising of the lateral part to avoid the lateral hooding is very important. You can see here, we are taking, now we are here, and immediately we come to join it together. But at the lateral part, there is this area which we remove it to avoid the lateral hooding, and this is very, very important. We have to leave 1 centimeter up, 1 centimeter down, at least to avoid the lag of thalamus. Here, usually 8 millimeter in the males, 10 millimeter from females, because this is a natural crease of the males and the females, and here we can remove it. Thank you so much.